I have a policy of always saying, yes, I'll meet you once.
I'm amazed that you meet with everybody who emails you.
Yeah, well,
Yeah.
I figured.
I do not.
Russ, thank you very much for joining us. It's great to have you here.
Thank you for inviting me. I'm looking forward to this chat.
We have known each other for, we were talking before we started, more than 20 years,
Wow.
which blows both of our minds. When we started working together, we were working on Proteome Analyst, which was a bioinformatics project long ago. So you've been working on health and biology for a long time. What made you decide to get into that?
So I've been in AI for about 40 years, since before machine learning actually began as a field. And I did lots of work in different areas. But then I met with Dwayne and also Dave Wishart, and they said, here's some interesting questions to look at. One was proteome analysis we worked on, those metabolomics. And that was like the gateway drugs. I went from that, I started looking at people across cancer and working with those wonderful people, and I got hooked. The problems were exciting, they were interesting, they were easy to motivate. I had wonderful collaborators who were really excited and wanted to get this insights. I could perhaps help a little bit with them. And they were mathematically interesting questions. I could also publish not just in the medical literature, but also in the machine learning avenues. So it's a perfect example of exciting things to work on.
And so would you say those first 20 years were like more pure AI?
Pretty much. I did lots of fairly theoretical work. A few applications, but it was mostly foundational work, which is fun. But I tell people I spent the first 10 years of my career proving theorems that no one cares about.
Right.
I still like proving theorems, but now they care about them. I have neat results. It's like about survival prediction later on, which I can actually give foundational results as well as applications.
And you also talked about having a lot of collaborators over the years. And I have also heard you talk about the fact that you get a lot of cold emails. Yeah. So how do you decide like what to work on, who to work with?
Yeah. So again, I've been averaging about 2 cold calls a month. People I don't know, people who heard me give a talk, or have a friend of a friend of a friend who know about my work. And they say, Russ, do your magic.
Yeah.
And so I get wonderful opportunities across the medical areas to help out. One of my recent themes, and this is a slight digression, is lots of people want me to build a tool which does a diagnosis, which is fine, but then I realized that diagnosis isn't enough. So 2 issues. One is, what is a diagnosis? It turns out if I just try to match what a clinician says, that may not be sufficient. So a kappa score, for people who don't know, is how much people agree. So, for example, I liked Indiana Jones. I hated Eraserhead. If you're the same way, that's kappa of 1.
Okay.
Kappa of negative ones means you hate the ones I liked and vice versa. So for things like diagnosing depression, what is the kappa score for that amongst trained
across
psychiatrists?
Different psychologists.
Across psychiatrists.
Psychiatrists.
It's 0.98, 0.95. It's 0.35.
Wow.
There's a huge amounts of disagreement between them. So if I'm trying to build a tool that does diagnosis, do I match this psychiatrist or that one?
Yeah.
Even if I were to solve that problem, next question, what do you do about it? Well, you give SSRIs, selective serotonin reuptake inhibitors, and that works half the time and has side effects. Why don't we just go to the treatment? Just say what treatment is best. So I like to have actionable decisions. So if someone has a problem that has this actionable characteristics, I'm really excited by it. So I can now say, I know what the answer would be. I know how to evaluate it because I can see when you take the action, what are the consequences? And is that useful or not? And again, I have a whole talk about this. I'll spare you the details.
So you're interested in actionable things rather than the actual diagnosis itself.
Right. A lot of the diagnoses are kind of constructs that when people didn't know quite what disease was, they said it's this composite of symptoms.
Right.
And that may not be the right way of thinking about it.
Yeah.
I'd rather go right to the treatment. And obviously, the diagnosis can be a help in that, but if it doesn't help you, why bother?
And it could be that like the diagnosis is a step towards the treatment, and the treatment could be shared across multiple diagnoses.
Exactly,
And
it is, in fact.
And so even if they don't agree on the diagnosis, maybe they would agree on the treatment.
Exactly. Right. And the whole point is, and again, rather than having this person's decision or that person's, we actually say, if we have a model that can say for this person and this treatment, what is the outcome? We can say what's the best outcome. We can evaluate the quality of that. So it's not just the treatment being right, it's how bad or how good was that treatment? What was the effect? For reinforcement learning people, we're very familiar with this idea. You look at the consequences of actions, and then you can evaluate it. I want it to be objective. That's another whole digression. But I think that's what I'm interested in. Not that I won't do other problems, but I'm very excited by people who say, I want to look at cardiovascular diseases, and I want to do PCA or CABG, which are 2 different treatments. Which one's better? Because that's, which one lives longer afterwards, because that's the next topic I realize.
Right.
So that's what makes it interesting doing.
Have you found any kind of pushback from that sort of approach? Like I can see some people maybe objecting to the idea of skipping straight to treatment.
There is some pushback,
Yeah.
but then I point out that the treatment, why do the wrong treatment? Wouldn't it be better to have the right treatment and do it before the negative consequence? Oh, but you need the diagnosis first. Why? Because everyone does it. Why? Because that's how we do it. Why? And then we stop talking at that point. Medical people are wonderful. They're hardworking, they're conscious, they're bright.
Yeah.
But there's a way they do things.
Yeah.
And you got to follow, from observations to symptoms, and then go to diagnosis and then treatment. But that's historical. And maybe there's ways around that. Or maybe instead of talking about the phrase depression, we talk about the people for whom SSRIs will remove suicidality. Make that the disease name. And now we're finding a diagnosis. It just happens to be correlated exactly with the treatment you want to apply.
Yeah. And I mean, like maybe that very regimented progression, like you just mentioned, I mean, that was very helpful up to now, but we do have these new methods and tools that you're working on.
Exactly. It can be, we can actually find objective answers, hopefully. And again, I'm not opposed to the tradition. If you have a diagnosis which identifies a treatment, I'm all for it. In a situation where it doesn't, we don't have to follow the traditions if we can do better. And we can define what better means. One thing I should mention, the complication, I contrasted following what a doctor does versus what doctors should be doing. That's a really important question of how do you do that? This one's much easier than that one, because if I want to do the best action, I have to decide amongst the different actions. So I've got a data set which has people with treatment, but what would happen with a different treatment? Counterfactuals, we'll never know. And that's one whole set of issues. And there are confounders that make it complicated, that if sicker people get an operation and healthier people get a drug, we find that lots of operations, people died from those. So obviously the operation killed them. No, there was a confounder. They were sicker, and that was why they got the treatment.
Right.
And that issue comes up a lot also. So it's a much harder problem, but one that I think we should be trying to solve.
And I mean, you did mention survival prediction, and that's kind of what we want to talk about, because I find it's really, really interesting stuff that you're working on. Let's start at the start. What is the survival prediction?
It could be time to death. It could be time to relapse or remission. If you have a mechanical part, it could be time till the part breaks. It could be a time until a student graduates. There's all sorts of things. Alana knows about that. The time until some event happens.
So this has implications that are just outside of the medical realm?
Oh, for sure. Many different fields. Customer churn. How long do people stop buying from Safeway? Well, that's a time to an event. Time until someone gets a promotion. All these are examples of time until X for some X.
Okay.
And that's the exciting part. It sounds like regression. Regression is given a characteristic of a thing. Tell me a real number, positive number, price of a house, for example. But what makes it different is something called censoring. And imagine I started studying in 1990. It's a 5-year study of people with cancer. And over this time, unfortunately, some of these individuals will pass on. So I know this guy lived 3.2 years or 4.7 years or 6 months. I know that. But the study comes to an end, and many people are still alive. They lived for 5 years, but what happened after? We don't know. So people may have left the study for various reasons. Again, they'll also follow up. We don't know what happens to those people. When I first started looking at survival prediction, I thought, well, I've got 1,000 people and 5 of them left the study. Why do I care?
Yeah. That's why studies have like big sample sizes.
Well, they have big sample sizes, but the percentage of censoring isn't 5%, it's 70% or 80%.
Sorry, did you say 70?
70
Wow.
or 80%. Prostate cancer, most men don't die from it. And so if studies are 10 years long, 96% of the men still have prostate cancer, but they're still alive. But the whole point is there's 96% of censoring. So what do you do about it? If you throw all the censored patients, you throw out lots of the long-living people.
Right.
That is
and that'll definitely change what your data says.
Exactly. It changes the data size, but also changes the characteristics of the data. How do you cope with them? And again, there's a lot of people who have played this game. I'm not the first by any means. People look at risk scores, a score that says, if you do this characteristic, your risk is 7 and your risk is 9. And what this is saying is the person with a risk of 9 is probably going to die before this person. And many people use that, for example, to do, I use the phrase biomarker discovery. That's saying, someone who's male, that protects you. It means you probably have a lower risk than female. Or if you're overweight, that increases your risk.
Mm-hmm.
They don't look at numbers, look at longevity. They just say this increases or decreases risk. That's one body work. Another body work says, let's look at 5-year or 10-year mortality. And lots of studies have done that. The famous Framingham study produced results that say your 10-year chance is this or that. And that's also a useful set of tools. And often there's ways to sort of cope with some amount of censoring and still get these type of estimates. Other tools look at something called the Kaplan-Meier curve. And now I'm going to use my hands because we don't get a whiteboard here. So this is a curve that says at time 0, this is time, everyone's alive. And over time, some people die off. And this is a percentage of people. And so a Kaplan-Meier curve gives a probability on this axis and a time on this one. And over time, you'll see that people are dying off. No zombies. The curve goes down there. The one goes, but you can still see like the median time is where it crosses 0.5, and that's 24 months or whatever it is. So people do that, and that says for everyone with stage 3 breast cancer, this is a curve for those people. But my interest is doing a curve like that for an individual.
Right.
So not for the whole population, but I should mention the limitation of the Kaplan-Meier curve. I forgot to mention this for the population. It says if everyone was identical, this is what you'd expect. We're not. There are different people with different characteristics, and some will die earlier, some will die later. That's why we have a curve, because not everyone dies at the median time. Can we take that idea and say, I can predict for Mr. Smith, his curve looks like that, and Miss Jones, her curve looks like that. And now you can use those to, for example, look at the median time. And so if Mr. Smith's median time is 5 years, and Miss Jones' median time is 7 years, well, that's a risk score.
Right.
I can use that. I can also say, what's the chance of dying in 1 year? Not for the population, for this person, I can give a 1-year probability or 5 years. I can do all sorts of things with this curve.
It's like if you have the survival prediction curve, you can from it get a risk score, and from it also get a 5 and a 10-year probability of survival.
All those things that I mentioned people want to do,
right.
The curve gets to do all those and more. It also is a visualization.
Right.
I can see you're unlikely to die in the first year, but by year 3, it looks really like you're going to die at that point.
Yeah.
We're not guaranteeing it's going to happen, but it does give probabilities that maybe you can use effectively. I've been working with many collaborators, many doctors in particular, and I show them this tool and I say, I want this.
So there's been a lot of excitement from people working in practice.
And once I describe it, they say, give me one of those. and so certainly in terms of, we talked about actionable decisions, if I do this treatment, here's the curve, and the mean value is 5 years. This other treatment, the mean value is 7 years. I'll do that treatment. All things else being equal. I just finished a report last 6 years, and I found 15 different projects, almost all of these survival curves.
Right.
So looking at time to death for cancer patients across different types of cancers from genetic information. Another one was looking at pathology slides for cancer. Another was looking at time until breast cancer onset, not death in breast cancer.
But like when it will first start.
Yeah, so maybe a tool that a woman could use to say, gee, if I change my lifestyle in this fashion, instead of being 7 years to onset, from a 35-year-old instead of being at age 42, maybe it'll be age 50. Maybe that's worth exercise. So something like that. Again, lots of all the issues about counterfactuals I mentioned still apply, but at least we have a tool to at least give estimates of that. And several other ones for ALS. You guys heard about COVID?
Yeah, it's come up a couple times, yeah.
Time until death from COVID. Time until hospital discharge. Time until hospital readmission. Right? Can we use that? So lots of exciting areas. So that was a long-winded answer, but it's an exciting area. I'll shut up for a second.
It's a very useful tool.
It's a very useful tool.
Yeah.
One thing that kind of strikes me when you're talking about this more individualized approach is, I mean, I do think when you get, your doctor says, hey, your risk of this over the next 10 years, we see with people with your lifestyle are this, it's pretty nebulous. Like it does feel pretty, whereas if it's more like, hey, if you stopped doing this, this is what we would expect.
Exactly.
That seems like it would be more likely to inspire an actual change that somebody might make.
Again, things I mentioned the Framingham study for cardiovascular and other diseases now. There's a website. You go there and it says, describe who you are. It says, here's your risk assessment. Right now, you're orange. If you change it, you go to green. Oh, I want to be green. But does that mean I live 5 more years or 5 more days or 50 more years? It'd be nice to know just the risk score, but actually be more specific. And again, it's based on just a few features. We can imagine using many more features as well. So yes, the risk score is a nebulous thing. Being able to be more concrete and say 5 years or 7 years or 19 years. And again, give the curve. We're not predicting the future perfectly. We're not saying that. It's saying here's a curve. Here's the stochastic things that might happen next.
And I mean, on another note, when we're talking about that individualism and that time to onset, it seems like it gives you more information in that I can see a situation where maybe I don't want to make an intervention. Like if it's like, hey, if you move to the other side of the country and you have away from your family and friends, you get an extra 3 months. Well,
yeah,
maybe that's not worth it to me personally.
Exactly. I talked about finding the best treatment, but what does best mean? Certainly in the case of drugs and so forth, there's efficacy, for depression, there's suicidality and anhedonia and things, you can get scores for that. But there's also side effects.
Yeah.
And what's best? Well, I can make a decision for everyone, or so could the doctor. Or a doctor can say, tell me what you think is important. Here's a vector describing what happens with drug A. Here's a vector with drug B. You decide whether you want this, whether you're willing to accept the fact that you won't be with your friends. Is that worth 3 more months? And maybe somebody will say yes, says no. It's not for me to decide. Machine learning can give you that vector.
Right.
And module all the issues of counterfactuals and so forth. But now, how do you find the best for that? I want to let that an individual or the caretaker or perhaps a healthcare provider say that. That's exogenous to the machine learning task.
When we're talking about these studies, you've mentioned that you need to handle people dying differently than people dropping out of the study. Is there like a technical detail that you could explain for that?
I talk about censored versus non-censored. In the case
what does censored mean?
So censored means I know that they're not in the study anymore.
I see.
And now, why they leave? It might be, one model is they just left. It could be administrative censored. The study's over 5 years, they didn't die. They could be censored because they just chose to leave the study. They just chose not to be involved. They might be censored because it's a cancer study. I wonder who dies of breast cancer, and this guy got hit by a car. This woman, I should say. And that could be another type of censoring. Another issue about survival prediction is the assumption is the time to death and time to censoring are independent things. The time until death and the last time you would be seen. And if the last time I'm seen is before the death, that's called censoring. If it's after, then I know the outcome. And these are independent. They're not always independent.
Right.
And now we get to complications of how do you model that?
In what way are they not independent?
Imagine someone knows he's about to die and decides to leave the study, to go to the other side of the country to be with his kids. Okay. So the fact that he was about to die meant it was censored. So again, if you assume that, if I tell you that someone was censored, I tell you that if I know they're going to die 2 days later, then I know what's going to happen next. So this dependency is a real challenge. Now, one problem is, it'd be nice, well, it's so fine, let's just model it, just look at the censor time, the death time, and try to find correlations. For every person, I see only one of those.
Right. Yeah.
Now what I do? There's something called copulas. There's a whole thing that people in statistics have looked at, and they have tools for trying to find ways to model it, but it's all based on some sort of prior understanding of the world. It's a hard problem, but there are tools people have developed, and I've got some papers on that, and it's one of my future work to try to understand it better. But thanks, that's a great question about the different ways it can be censored.
And when we get to the end of the study, if they're still alive, there's no sense of how much longer they lived. You have no information about that.
That's correct.
Yeah.
So that's in general. Now let's talk about censored data. I've got people who 5 years later left the study. Well, they moved to Saskatchewan. Okay, for $10, I'll track them down. I'll find what happens.
Right.
So I might be able to answer the question sometimes. I can imagine a budgeted learning approach to desensitize patients.
Right.
Right.
Of course, other problems that some patients, again, I'm looking at breast cancer studies, a woman who was hit by a car, I won't ever know.
Right.
So all of a sudden I know the answer, the uncensored, there's censored but learnable, and they're just censored. I'm never going to find out. No amount of money can find out.
The idea is that, like, amongst the people who lived to the end of the study, you could spend a little bit of resources to try to track down some of them, the ones that might help your model the most.
Exactly. And now the same way for so active learning is a field, budget learning, if you have a constrained budget for that. You can now say which patient is the most relevant one to find out the outcome. Here I can find which of these subjects is the one I should track down. That's a cool question.
Yeah, that is a cool question.
From what you said earlier, it does sound like this is dealing with the censored data is one of the big differences between like your approach and the more traditional risk-based one.
Make a dichotomy between the censored data is what makes it survival prediction,
right,
as opposed to regression. Now, within censored analysis of censored data, what are the approaches? So there's risk scores, there's one-time probability, there's population-based, and there's individual survival distributions.
Right.
Does that make sense?
Yes. Yeah. So I guess my question was kind of going back to the machine learning side of things. Like, how is this something that we could have done with non-machine learning methods? Like, how does that fit in to making this all work?
Well, traditional models, there's statistics-based models, would do, again, I use the term biomarker discovery as my catch-all phrase for not trying to make individual predictions,
right,
but trying to say this feature is important. It's really important to a person's weight's really important, but eye color is not. Gene 7 is important. Gene 19 is even more important. Gene 1, 2, and 3 just don't really matter here. So there's a lot of tools that do that, and that's most of statistics has been involved with, most statistical techniques.
Right.
And there are other tools. There's something called the Cox proportional hazard model, which I'll skip the details, but it's for giving risk scores to individuals. Basically a linear model, and they see the coefficient of the linear model. When that coefficient looks like 0, they say it doesn't matter. And that's been a tool that, again, I consider it a machine learn technique, but it predated machine learning approaches. And there's ways like accelerated failure time, where they give curves, but on a very, very parameterized, there's like 2 or 3 parameters that define the curve. And that tends to not be for individual level in general. There are some exceptions.
Sounds like a lot of like impressive progress so far, but what are kind of the next steps for you on this work?
Well, I've already hinted at a few of them, but great question. I'm really excited about it. Does that come across right?
Yeah, a little bit.
So one is this budget learning question. That's a big issue. Another issue is I talked about the nature of the centering. It could be independent or it could be correlations. We start asking that question, you can start asking other related questions. So we're working on ALS, this horrible disease has degenerative disease that people will die from eventually. Lou Gehrig disease that gets worse and worse. We had a paper that predicts time until death, but wouldn't it be interesting to predict other things like time until you can't swallow, time until you can't move, time until you can't feed yourself? So can we predict all those things? Now, unlike the first case where, I could talk about time to death by cancer or death by cardiovascular or censored, those are disjoint. These are not disjoint.
Right. Yeah.
Someone could have, 3 months later, they can't move their hands, and 5 months later, they can't swallow. And whereas 30 months later, they can still walk, right? So those are censored. How do you cope with that? So I work with ALS people who are really interested in this question, as am I.
Yeah.
How do you cope with multiple events? That's the second big challenge.
I just want to say, that could have a huge effect on people's quality of life. Like, if you know you're going to have a disease, knowing when you die, that tells you something, but also knowing how things are going to change over the course of the disease.
Exactly.
You can plan, like, if you want to go skydiving, that's a tomorrow thing.
Yes, great example.
You definitely prepare a little bit. And I think it probably helps, the psychological or the problems with dealing with that if you have a little more information.
Right.
And once again, my interest, of course, is not just what happens next, but what can I do about it?
Yeah.
Maybe there is a treatment that, again, this is not the case, but imagine there was a treatment that delayed the loss for lower body problems. If I knew that was happening, but I might have some other side effects. If I knew it was happening soon, I might decide to do it.
Yeah.
Again, actionable decisions,
Right.
not just here's what's happening, here's what you can do about it.
Yeah, providing people with more information to make more informed choices.
Exactly. I should mention we've done a lot of nice progress. My team, I've got some brilliant students and colleagues. One question is, how do you evaluate the survival model? So again, we talked about why I don't want risk scores, because risk scores just say who dies first, and that's, again, my caricature is, you're about to die, Mr. Smith. Oh my, what do you want to know? Tell me, am I going to die before him? That's not what happens.
It's not what people want to know.
Yeah.
I like
Not
to
your main
live.
concern.
We do that. So we have models that can perhaps do that. How do you evaluate it? Well, you look at the L1 loss. I predict 5 years. People actually died in 6 years, a loss of 1. And that's great for uncensored data. What about censored data? I predict 5 years, and someone was censored censored at 5.5 years, that's 6.5 years. When do they actually die? Well, I'm off by at least half a year. You can get a better estimate. It sounds like a hard problem. We actually have a really cool way to solve it. We actually way to evaluate the evaluation measure and get ones which are quite accurate. So it's one of my favorite results in the last year or so. I've looked at survival predictions for many years. I started saying, my first question is, how do you evaluate these bad boys? How do you decide this is better than that one? And we didn't know a way to do it because I don't like C-index, which is who dies first. I didn't like calibration, which is just how we correlate. We actually produce time to event and get a meaningful estimate of how good that is, and we use that for many tasks. One thing I like about survival predictions, if Alana says, I've got this whole new result that no one knew about regression, I say, come on, Alana. I mean, people looked at it for dozens of years, for decades. I'm sure that there's no foundational ideas in it. Survival prediction as a machine learning enterprise is relatively new. And things like, how do you evaluate? How do you get actual time to event? Got a way to do that. How do you evaluate that? There's people who sort of play little games which are all unsatisfying. I've got him, I'm very satisfied by it. I think will make a big impact for people looking at that. It's exciting because we can do things which are really making bold statements and solving questions that people really want to solve. End of digression.
So maybe while we're talking about bold predictions, what's the future of AI in medicine? Are you optimistic about this future?
Oh, yes, very much so. One of the impacts of AI is people are aware of the fact that the world is complicated. I think the traditional model is, I tell you 5 factors and I can predict the disease. Well, yeah, maybe, but can you pick the treatment? Well, that's good enough, right? It works half the time. That's good enough, isn't it? No. Can we do better than that? Well, it's going to take more than 5 features. No, I don't want to use. If it's your mother, it took 20 features, you'd probably do it. And maybe not linear. I think people are starting to accept the fact that the world is complicated. I think machine learning has shown that you get good answers by complicated models. So I think I'm optimistic people are starting to appreciate that and starting to believe that.
Do you think people are appreciating also that sharing data is?
That's another big thing. Of course, thank you. I'm all in favor of patient privacy. We want to preserve that.
And that's an important aspect.
Given that, if there's ways to share it in ways which preserve the privacy when they're important, we should do it. And it's starting to happen.
Okay.
It's starting to happen across the world in many different locations. So we get data sets to play with. Again, I wouldn't be able to do what I do without the wonderful colleagues I have. And they couldn't do anything without the data.
Yeah.
They do the hard work of doing the experiments and tracking doing the experiments to start with, getting the permissions and so forth. And I and my team are conscious of how important it is and how important the privacy issue is and honor all the requirements, of course. But then we can do something with it. We get to see what's happening. The data's available.
Every link in that chain is important and does a really vital job.
Exactly.
You were saying even yourself earlier, when you do talk with people who are practicing medicine and you show them what kind of available options there are, there's a lot of excitement there, it sounds like.
I'm overwhelmed by possibilities. I've got lots of tasks that I just don't have time to do. I get to be choosy, unfortunately. I would like to help other people as well. But yeah, there's a lot of excitement. The medical community is aware of the fact that Russ is magic, right? There are ways to make it happen. And again, I'm always honest and sincere in saying, look, this is a way you give me data and I can give you a response. I can tell you whether you should believe it or not. Because at the end, I can use technologies that say, this is how good it is. And they can then try it out and see if it works. So it's a great collaboration.
And what are the hard problems that you don't think are quite ready for AI? Are there any sort of things you...
I wish someone would solve causality.
Solve it.
Yeah, if they could just, bang that out in a weekend, that'd be great.
My trajectory was I spent 30 years getting really excited by machine learning solving all of our problems because it really solves. I can find patterns in data, and that's great. And then I realized the problem I care about is treatment, not diagnosis. And to get to that, counterfactuals and causality and all of a sudden, I realized that, it's not just, gee, if only I was smarter, I could solve it. The data alone doesn't solve it. You need to understand the background. You need to do randomized control trials, which are expensive and hard to find. You need to decide the assumptions you're willing to make to get something like a causal inference. There's also mechanisms by which you can do the biology, put on a white smock and do all the laboratory work and maybe find exactly how to solve it. And that's happening. And again, if there's one gene or 5 genes, you're fine. Remember I told you the world is complicated? If there's going to be 1,000 genes, they're all related to it, and there's different pathways involved, and it interacts with the metabolites and with all of a sudden, the techniques that work for 1 or 2 genes just don't scale up.
Yeah.
So it'd be nice if we could solve causality. Here's data, we can do it. So I'm frustrated it's not going to happen. Someone's going to crack this nut.
Yeah.
I'm looking forward, or at least make progress on it. And again, one of my things I'm aspiring to is to help out in this area. But I'm excited by the fact that we can find complicated patterns, and people appreciate complicated patterns are important. I'm disappointed by the fact that the world is such that just finding complicated patterns is not sufficient to find the best treatments. Not yet.
Yeah.
Stay tuned.
You were talking about some of these aspects of this during Upper Bound last year.
Oh yes, yeah. First, Upper Bound's a wonderful opportunity. It gets thousands of people from around the world to come in, and to hear about the whole space of AI machine learning here in Edmonton as well as other places. I was privileged to give a talk last year about this objective actionable decisions at this Upper Bound. This year, maybe I'll do it again. I don't know the details yet, but I think that's my philosophy these days of something I think is, it's something that when you talk to a doctor or anyone else, they say, yes, of course we're doing that, aren't we? Oh, we're not. Good, let's try to get that to happen. So I think there's a big interest in that. And Upper Bound's a great resource. I'll be there if you want to track me down. I'm easy to recognize, right? I'm left-handed, it helps at all.
Yeah, maybe skip those cold calls you're talking about and just regular person.
Yeah, track me down. I do escape calls. Oh, sorry, my cell phone's going off again.
Thank you, Russ, for just a really fascinating talk and a bit of a peek into that Russ's magic that you were talking about. Really appreciate it.
Yeah, thanks for coming by, Russ.
My pleasure. Thank you. And I'm excited. Thank you for giving me the opportunity to talk and for me to tell my philosophy and for what it's worth. And,
yeah.
Look forward to continuing to work in this area and working with. Maybe 20 years from now, we'll keep talking about this.
I was going to say, we should always have people come in the week they're working on their NSERC.
That's
You had just a great overview of what you've been working on.
Yes.